John Mutua. I'm a programs coordinator here at the Institute of Economic Affairs, and I also head the program on public finance management. So today we are pleased to share and discuss the issue of universal health coverage in Kenya. I know there have been concerns about what's been happening around this, and so that's around the UHC, especially the progress with regard to implementation of universal health coverage, because there isn't much information that's provided, and we're hoping that this webinar will shed some light on that. So before we introduce our speaker for today, as you can see from the program, we only have one speaker, and so I'll just take a few minutes to set the context and then invite the speaker, and then thereafter open it up for question and answer, and hopefully by around 11:30 we should summarize this and close. So the speaker today is actually Dr. Jared Nyakiba. He works at the UHC Secretariat at the Ministry of Health, and I will, of course, give him an opportunity to introduce himself further. So without further ado, just in terms of context setting, so I hope you can see the slides.
Yes, John.
Yeah, okay, so the issue that we'd like to discuss is basically what the COVID-19 pandemic means to the realization of universal health coverage by 2022. So as of course many of us are aware that universal health coverage is actually part of the Big Four agenda, and so there's a typo there. Government has made a commitment to achieve this by 2022, so that should be 2022. And so the objective of universal health coverage is to protect people from financial hardship or financial risk, if you like, of paying out of pocket. So currently, the data from national health accounts shows that out of pocket accounts for about 28% of total health expenditure, whereas WHO recommendation for this is between 12 to 15%. And so the idea of UHC is obviously to provide affordable access to affordable healthcare, and in turn, of course, increase the equity and equality in healthcare. And so we know that the issue of healthcare financing is a major strategy towards the realization of UHC, and of course the current NHIF reforms that have been in place for the last decade, and the idea is to be able to pool resources so as to finance healthcare coverage. Some of the reforms are in line with of course, we have the introduction of civil servants schemes. We have things like some of the reforms have gone towards broadening the spectrum and trying to encourage the people in the informal sector to be able to register for National Health Insurance Fund. And I believe the speaker today will be shedding light on that. So I will not go much into that. Now, this graph, which is something that I picked from one of my colleagues, Darmi, some work that she did, it shows the registered members of NHIF. And you can see by 2018-19, there are about 8.5 registered members. This is against the target of 19 million registered members by 2022. And this is actually both formal and informal. So you can already see in terms of the number of registered members of NHIF, we are still a bit significantly off the target. And we, of course, know that we have this pandemic here and it has certain effects. So I'll not go into the details of those. The other thing to note is as contributions to NHIF increased by 22% between 2017-2018 from 48 billion to 58 billion in 2018-2019. But this is obviously likely to be affected because of the expected slowdown in economic activity and economic growth, which is projected to be around 1 to 2% in this year due to the effects of COVID. So again, what does this mean to the roadmap to UHC? With regard to the health system, again, the other objective of UHC was obviously to strengthen the health system. And we have this pilot project, the pilot in 4 counties. So the question is how we fared in this in the pilot, and how this will extend to the full rollout. Of course, we know that the COVID actually has exposed how the healthcare system in the country is unprepared. Is not prepared. Is not well prepared to respond to outbreaks and pandemics. And just to show, if you look at this correlation between the number of healthcare workers per 100,000 population versus public health facilities per 100,000 population, you can already see the southwest quadrant. That's where, so basically this shows there's a spatial concentration of healthcare workers and facilities in the entire country. But the biggest challenge is actually in the southwest quadrant. So in this quadrant, you can already see the likes of Mandera, Turkana, Wajir. Those are counties where the total public health facilities are quite low. And basically it points to the need to ensure that we continuously strengthen our health care system to meet healthcare needs of the country. Then the other effect of COVID, and this is just something that I picked also from the expenditure estimates, development expenditure estimate, is that in order to cater for or respond to COVID, the UHC rollout budget was actually reduced by 9.4%. Again, was 9.4 billion shillings for 2019-2020. So again, what does this mean to the implementation of, what does this imply to the realization of UHC by 2022? And so there are 3 questions that we would like to pose this morning, and this is what the speaker will be trying to shed light on. The first is just basically to enlighten us on the status of the implementation of UHC, and secondly, to also mention what the effect of COVID is on this roadmap. And then thirdly, to let us know what measures the ministry is taking or has taken to ensure that we stay on track in the implementation of UHC. So these are the 3 key questions that Dr. Nyariba will be shedding light on. Thank you. So I'll stop sharing this and then and invite Dr. Dr. Jared Nyakiba. So you can share your slide and you can introduce yourself as you load up your presentation.
Thank you, John. As introduced, my name is Dr. Jared Nyakiba, working for the Ministry of Health, UHC Secretariat. So yes, so maybe just to go straight to my slide. Presentation for today, which will be focusing, yes, on the 3 questions that John has posed in terms of the 1, the status of UHC, 2, the effect of COVID, and 3, some element of the measures that are being taken to ensure that. So I have started sharing. I hope you can see that. John, can you see that?
Yeah, I can see it. So you can please expand the screen. Yeah.
Okay.
Thank you. Yeah.
There we go. So yes, so the presentation of will be we'll be talking about so the first question on the status will be probably split into 2 components or 3. 1 being the pilot, some element about the pilot, UHC pilot. 2 being the scale-up process, how we are scaling up across the country, and then some element of the future aspirations. And then now we look at the effect of COVID and some of the now, when it comes to the measures, that will be a mix in between the first 2 questions. So let's begin. So we begin with a quote from the former DG of the World Health Organization, where she said that she regards UHC as the single most powerful concept that public health has to offer. It is a powerful social equalizer and the ultimate expression of fairness. And I'm happy that John mentioned the issues of equality and equity. And as we all know, we have constitutional, provisions in terms of Chapter 4 Bill of Rights, Article 43, when it comes to socio-economic rights. So Kenyans have now a right, an entitlement to the highest attainable standards of health. And therefore, this is an equity issue, and this is an equality and rights issue. This is also in line with the SDGs, particularly SDG 3 on good health and well-being. And this also seeks to achieve that. If you look at the targets for SDG 3, then you are talking about universal health coverage, access, affordability, etc. So when we speak of UHC, we are referring to our collective aspiration, right? And this was the aspiration of His Excellency the President when he declared the Big Four agenda, and UHC being part of that all Kenyans have access to essential quality health services without suffering financial hardship and leaving no one behind. It is important to underline all Kenyans, and therefore the equity issue. It is important to underline that universal health coverage is not universal health care. So we are not saying you will access everything under the sun. So it is access to essential quality health services. So there must be a process by which we determine what is essential and we ensure quality. Then suffering financial hardship, healthcare is one of the major contributors to hundreds of thousands of Kenyans becoming poor on an annual basis. So we need to ensure financial protection. And of course, equity, and you are aware of the discussion in the Senate, where equity and equality has become the key buzzwords over the last 1 week or so. So we want to leave no one behind in this process. So we usually look at it as this, four quadrants with one at the center. So we are talking about affordability, that healthcare needs to be affordable, and therefore the financial risk, protection comes in there. Accessibility, and therefore equity. Kenyans need to access healthcare equitably across the country. And that is, as we are all aware, we have significant inequalities that we need to address. Service availability, so the services need to be available to ensure that, and of quality, to ensure that Kenyans can access them. And then quality, and this is usually looked at in many dimensions, but largely quality referring to safety, timely delivery, effective care, efficient, both in terms of care, but also in terms of systems and processes, equitable, we've said, patient-centeredness, etc. And if we do all this, then we achieve high quality, people-centered and integrated interventions. And as we know, we are not in this state yet. We are not there yet. We have issues in affordability. We have issues in accessibility. We still have some challenges about that. We'll talk about that shortly. We have issues with quality. We are not doing, we are doing reasonably well, but we could do better in terms of quality. And therefore we need to, and we have issues with shifting the system towards patient, people-centered care orientation. So that's pretty much when we speak of UHC, that's what we are referring to. We have critical drivers. So we look at it as three critical components. One being population coverage. And this is what, John was referring to. We want to achieve 100% population covered with that package referred to as essential by 2022 or thereabouts. Now we are at, and as John projected, we are at enrollments of around 19-20% health insurance, membership in the country as at 2018-2019, and of which 19% or so of that is actually NHIF enrollment, and then the other 1% or so being private insurance. So how do we shift that now significantly towards 100%? So we have vulnerable populations, and by the way, Kenya has made significant, previous efforts towards UHC. A lot of times when you speak of UHC, it is perceived as a very new thing, a new concept. But we have made several attempts towards achieving some elements of equality, some elements of equity, some, progress towards UHC. Vulnerable populations, the elderly, children, the poor, the people living with disabilities we've made some efforts to cover them. Hard to reach areas, and that is a current discussion. Pregnant women, Linda Mama, for example. So that whole, Edu Afia, etc., etc., etc. All these efforts to achieve coverage. So when it comes to quality health services, we shall be talking about this. There is quite a bit there in terms of how do we strengthen primary healthcare. So we'll talk about that. Human resource management, that has been a main topic for the last several years. How do we ensure availability of various inputs, medical equipment, medical supplies, and then how do we leverage on IT and information systems? How do we digitize health? I think we've had some progression towards that. Then financial protection, which I think was highly, mentioned by John's context presentation. So how do we now shift towards a more sustainable, model for the country? So our approach, Kenya's approach has been first largely two-pronged, as I referred to earlier. One, we had a pilot in 4 counties, that is Machakos, selected because of the high road traffic accidents, Nyeri, which is high in non-communicable disease, Isiolo, to give that pastoralist, semi-arid kind of experience, and Kisumu, which is more urban and more of highly infectious diseases, etc. So this started out in 2018, launched by His Excellency the President in Kisumu. 2018 was to end in December 2019. We had an extension of one month just to start giving the 4 counties some element of transition between pilot and scale up. So we'll talk about that. Then number 2 is the scale up now. And this scale up will take a phased approach. No country has achieved UHC as an event. You know, countries have taken 18 years, 10 years, you know, etc. To achieve UHC. So UHC is a journey. So we have UHC in 2 components there. Component 1 being a lot more input investment oriented, because we have significant challenges in our health facilities that we need to address. So we need some health strengthening, you know, for focus on primary healthcare as we scale up. Then component 2 is now when we start shifting into more of social health insurance, more of output-based financing, more of strategic purchasing, and therefore purchasing of quality healthcare interventions. So this gives you that journey also, just gives you a pictorial that UHC is a journey. We started with phase 1. Some would argue that there was a phase 0 before 2018. We've had, you remember what we mentioned, Eduafia, you know, we've had Linda Mama before. We've had user fee for gone, level 1, 2, 3 is free, you know, etc., etc. So we've had a lot of interventions. We had HISP, we've had etc., etc. So some would argue that would need to put a phase 0 there, but phase 1 being the 4 pilot counties, which was more input oriented. So we give you, so you employ staff, we give you medicines, you know, we give you equipment, community health kits, etc., etc., etc. That are, we give you funding for you to conduct certain activities. So those were in the 4 pilot counties. We'll talk about that shortly. And then we are now shifting to phase 2. We shifted to phase 2 actually, which is again now all counties, but also input based. And this started out, you know, January to June this year, so in the last financial year, which was highly input based. So we were giving all 47 counties health products and technologies. Those are medicines, essential medicines, and medical supplies. The new term is health products and technologies. It's a wider term. So HPTs, human resources for health, you know, and you've seen the adverts both in terms of the presidential youth empowerment, PSC youth empowerment interns, and the contractual staff that we shall talk about, giving them basic equipment, setting up of primary care networks, you know, etc., etc., highly input based. Now we are supposed to be actually in the medium term, post July 2020, starting to shift into having a blend of, you know, input and output based. So setting up of a UHC fund and, you know, defined package, operationalizing primary care networks. We'll talk about them. This is now ongoing as we speak, while also still providing quite a bit of the inputs. And then more in the long term, you know, moving towards a more reformed NHIF as a main and converting NHIF through reforms to become a strategic purchaser, all right, of outputs as opposed to the current scenario from health facilities, etc. So this is sort of like the path, the journey that we expect to go through. So to emphasize the shift that UHC is through a primary healthcare approach. Kenyans, as you know, our health seeking behavior is largely towards the higher secondary and tertiary care facilities. And you shall see that shortly, even from the pilot. So we want to now shift towards level 1, 2, and 3, lower level facilities, early treatment, early diagnosis, in the, you know, as convenient as possible, nearest to your home, kind of services. So primary healthcare services for as much as 85% of treatment and care should be handled at the lower levels. So this includes primary healthcare. We'll talk about that. Community health, which is now setting up of the community health units and volunteers. Health system strengthening, which we've talked about. How do we make sure human resource for health is available? And by the way, you notice that all these components, public health, in terms of surveillance and response, prevention, sanitation, specialized services. How do I access an ICU? How do I access a hospital bed, a quarantine center, an isolation? All this has become even more urgent and even more important and even more apparent as a result of COVID. And therefore, this is please keep thinking between the interplay between what we are seeing in terms of COVID and what we are seeing in terms of UHC as we are going along. So the investment for the pilot counties. So for the 4 pilot counties, a total of around 4 billion, 3.9 something was invested in the 4 pilot counties in various areas. We had 5 areas. So one was public health services. So CHMT is for the county health management team, supervision, including sub-counties, public health inspection, disease surveillance. We actually provided funds to the 4 counties to do that. Community health services, now this component, 30% of that component was to buy community health volunteer kits. And then the remainder was for community formation, capacity building, community dialogue, community action days where you actually go out, meet the community and have dialogue and public education, etc. So then health system strengthening, which is most, a lot of the inputs we've talked about, human resource for health, etc., etc. Basic and specialized services. Now, 70% of component of this particular, section went to KEMSA. And people usually misquote. It is not 70% of 4 billion that went to KEMSA. So what went to KEMSA was actually 1.6 billion shillings, which is actually 40% of the overall pilot cost. 40%, not 70% of the overall cost, but 70% of the particular component went to KEMSA for commodities. So these are medicines, medical supplies, the gloves, etc., and the basic lab supplies, and then basic equipment for level 2 to 3. And then 30% of this went to O&M, for level 4 and 5 facilities, because remember, they were not charging at that time. Specialized services, funds were also provided, a small portion for access of services in level 6. So referrals, for example, to Kenyatta, or, the pilot provided funding for that. So what were the lessons learned? I'll be quick about this. I'll try to avoid going through every part. So number 1 was human resource. Very interesting. The pilot targeted to recruit, 2,900 healthcare staff, but only 17% of this were, actually recruited. The hiring process was slow because of various reasons, including several of the counties not having active county public service boards, and that took a bit of time. Resources being made available for the recruitment, that took a bit of time. So mitigations now as we move forward is we have critical gaps in our human resources for health that we need to fill in all these counties. We have also interns who are learning, but at the same time providing services. So there is need to also, increase reach in the rural areas. So deploy the interns during their rotation to rural placements. Now interns are now, and this has already been done, interns are now doing 2 months placement in a rural facility under supervision. Organize specialists to do outreach services. So you have KNH doing outreach in 23 counties or 24 counties. MTRH also doing outreach services, like cleft palate, procedures, etc. in another 23 counties or so. So we need the services to go closer down to the level 5s and capable level 4s. Community health services. Community health service, the volunteers are actually very critical in mobilization, advocacy, public education, community-based services, etc., and referral. Their role is even now more important in terms of home-based care for COVID. So that is quite significant, and we shall see the update on that. Establish community health units. Counties were to facilitate payments of the stipends to that through county legislation. Primary health care is the way to go. It's more cost-effective and more, more efficient, and that is the way to go in the scale-up. So we need to link our level 1, 2, and 3 to a level 4. So the way this would work is you'd have the level 4 linked with a set of level 3 and 2s and 1s, so that we have coordination, we have improved service delivery, we also have outreach to the community. So if you need a physiotherapist from the level 4 to visit a mother at home, then the community health volunteer links that all the way up, and the physiotherapist goes out and sees the patients who are not able to come to the facility. So referral system was not appropriately utilized. As I said earlier, this led to overcrowding at higher hospitals. So we need to discourage self-referrals, and we need to have some gatekeeping mechanisms, and we'll talk about this. We need to strengthen the health facilities. I think we've talked about that. Service delivery, there was increased utilization of services, actually across the quarters, around 20 to 40% increments in the services, but most of these patients were again flooding the level 4 and level 5s, which obviously led to prolonged waiting times, and that was an interesting experience. So strengthening health systems in the primary facilities, so that we have Kenyans accessing services there. Commodities, we had quite a number of issues around there. KEMSA did fairly well, but there were certain limitations within KEMSA. So lack of standardized equipment and machines. This is now within counties. Every county has contracted different suppliers, or leased, let me put it this way, leased different sets of equipment. Now, these different sets of equipment come with their own set of reagents. So it is very difficult for KEMSA to actually stock some of these reagents, because the economies of scale don't make sense. You're not achieving that. So we need to now maybe get a national policy on some sense of open system. And the way you can make a closed system open is by adopting it in multiple hospitals and counties, so that you gain those economies of scale significant for KEMSA to now stock and distribute. Then we need to expand the range of products, and delivery times need to be reduced. So we need some KEMSA reforms to actually strengthen KEMSA's ability to meet the needs of the counties. Health information, real-time data is critical, but we're having challenges with receiving the data. So we need to invest in ICT and infrastructure. Financial flows, we had issues with timely flow of funds to the facility. Funds from national flowing to the county, from the county, the Department of Health now distributing the funds to the facility, and then the facility getting authority to utilize those funds. There were significant delays in that process. Then number 2, money reaching the facility is significantly lower than money that was disbursed. So we have some challenges there in terms of financial autonomy and retention of funds for the purpose for which the funds are intended for, right? So some of the counties actually took the money and used it for, cleaning markets and other things, and that there's a bit of a challenge there. So the facilities are incurring cost but not receiving reimbursement, and that creates limitations in providing services. So we need mechanisms for timely release of funds, and we need to increase resources as we also look at financial autonomy. Governance and leadership, we had coordination structure set up. at national and county, but we need to actually make it more active to enhance coordination. Engagement with enabling sectors was not very optimal. So a facility is receiving more patients, but there is no water, right? Or there's a blackout, and they don't have a generator, or ICT is down, so they can't send their M&E reports. So all these other sectors that are not in, health sector, but are key to the provision of sectors. So in the scale up, we want to increase this engagement with these other ministries and sectors to enhance service delivery. So that was the pilot. So as we move to the scale up, we'll have, and I hope you can now relate at this point, moving forward, that we need to strengthen promotive and preventive healthcare. We need to define primary and strengthen primary healthcare networks. We need to enhance coordination of care at the lower levels. We need to. We had started working on a sessional paper on social health insurance, but that has now been readdressed to a UHC policy, which is in draft form now, going through final stages. We need to operationalize all the level 2 and 3 facilities. We have actually several level 2 and 3 built by CDF, built by, that are not operational because they do not have healthcare workers. And they're as high as 20 or 30 in particular counties per county, So quite a number. So we need to make sure that we operationalize these level 2 and 3 facilities by placing the inputs that they require. Health financing, as I referred to, we need to ring-fence health financing at county level. The agreement with the counties at the pilot and also at the scale-up is that at least 30% of total county budgets to be dedicated to health. We have counties that are above 30%, some are actually almost 40%, and we have counties that are quite a bit low, but majority of counties are, around 27% or so on average. In terms of that. Implementation of facility improvement fund guidelines. This will just ensure facility autonomy in terms of finances. So if I am Embu PGH and I collect 2 million shillings, then I get to retain a significant portion of that. Then I can direct that to service delivery. Then we have conditional grants by the national government. We'll see that. Gradual, financial protection through a UHC scheme and provision of basic infrastructure. So we'll talk about this again. So this is basically the investment areas, the focus areas informed by the pilot for the scale up. So we've had a very long process, We've had a lot of intergovernmental consultations with counties. I think we've had, 20-something meetings now with counties and development partners. We've done joint mappings and assessments for human resource, for even for equipment, actually. Counties are now engaged in quantification and forecasting of medicines. What do they actually need? And we'll look at that. There's a lot of human resource distribution and rationalization supposed to, be taken through. Recruitment and actually placement to deal with the gap. So we have a two challenge here. We have gaps, but on the other hand, we have, some element of maldistribution or productivity issues or, performance issues that need to also be resolved. So we need to establish joint technical working groups. These are actually there. We have intergovernmental committees with the counties and partnership. We have a partnership framework now that gives that engagement a structure. Capacity building for county and national and establishing governance, revitalizing supervision at county and mentorship from the national level. We've had quite a bit of challenges around this. We need to verify and validate some of the reports that we are getting from facilities and from counties. Expand basic infrastructure, that is energy, roads, ICT. I'll talk about that shortly. So maybe, just some update of where we are, and I think that was where we are now. So in terms of the UHC policy and the UHC fund regulations, development of this is ongoing. We've actually had some meetings with the counties to take them through the policy. They've given feedback, and we are now inputting that. So actually, we should be having a draft 2 by this week, so that we can now move to stakeholder review and validation. Now, actually, now as we speak, there's actually a meeting with the Treasury on the UHC fund that seeks to be a fund at national level, probably at at NHIF, that would be home for UHC funds, to ensure that we have some element of ring fencing of funds towards UHC. So that approval was actually given in April, but operationalization, setting it up is what's going on. Essential health benefits package. Number one, we had an expert panel that proposed a benefit package, but that package was what we actually needed was costing quite a lot of money as opposed to what we had. So we've gone through a process of rationalization so that we can start from somewhere. And what is now going on is some meetings with the NHIF in terms of operationalizing that package. So comparing it to super cover, for example, how do we, so that we have a national package that Kenyans can access. This financial year, we hope to provide that to 1 million households in consultation with the counties. So there's some mapping of indigents, starting with indigents, those who cannot pay to go. So the role of NHIF is actually very key. Intergovernmental agreements, last financial year we had 46. Nairobi is the only one that didn't sign because of the issues with NMS, which is now being resolved. And then drafting of agreements for this financial year is in its final stages. So every year we have to actually go into agreements with the counties. This spells out the role of the national government and the role of the counties, their roles and responsibilities. Primary healthcare. So the Cabinet Secretary Mutai Kagwe launched the primary healthcare framework in Nakuru PGH in July, I think actually 3 weeks ago, together with the community health policy. So these are the instruments now through which we are implementing primary healthcare. They are available on the MOH website. You could have a look at them. Then training of community health volunteers, setting up of community health units is ongoing. So far, so Kenya needs 101,000 community health volunteers. We had around 68 or something, 69,000 community health volunteers that were existing previously. So what we are now doing is bridging the gap of 31,000 community health volunteers. So far we have 26,000 that have been trained in over 35 counties. So the other counties are also working through the motions to finish up on the 5,000. This has happened actually over the last 1 month. So by Kenya Red Cross and Ministry of Health, which is an interesting collaboration. So sensitization of health workers. We were to sensitize all county staffs because we need to bring everyone to the same page. And then COVID landed. And so this is one of the effects or impacts of COVID. It has disrupted quite a bit of consultative meetings and, capacity building sessions. But we've had online meetings now towards that. Recruitment of 4,000 youth empowerment interns for the Ministry of Health. Remember, this is across government, but this specific number was now for the Ministry of Health and counties, or the health sector per se. So this is ongoing. We are at around 2,800 so far. Recruitment of, now initially there were 5,550, but due to some discussions from the counties in terms of remuneration, this number was increased to around 9,000. And recruitment is still ongoing, and we are at around 5,800. and that number is probably higher today because these recruitments are ongoing. Again, disrupted by COVID, interviews, etc., are all meetings, and government meetings were banned for quite a bit of time. So essential medicines and medical supplies. So the national government has provided a conditional grant to counties. One on medicines, last year around almost 6 billion shillings, actually, 5 point something. And then on equipment, we are still working on the equipment part, and it's part of the 9.4 billion shillings that John referred to, that were in quotes retracted back to National Treasury in the last financial year. So we are now working on having them reinstated for this financial year so that we can provide equipment for level 1, 2, and 3. And also for level 1, this financial year, we are providing community health volunteer kits. So these funds are actually available as drawing rights. DRs are drawing rights at KEMSA. And this was actually done. And maybe an update on that. This started in February. So 40 counties in Q3, placed their orders of around almost 1.8 something billion shillings. And all the 40 counties were served in Q3. In Q4, because we started around March, actually, February, March. So the spillover of Q3 to Q4. And then Q4, we now have 43 counties that have placed their orders. Around 10 counties have already been served, and that is still ongoing. So it's very interesting that these essential medicines, medical supplies are also, being used for COVID also. So there's an interesting interplay there, because gloves are gloves, so they will be used across, for example. So we have an essential medicines list reviewed for 2019. This is the list of medicines that will be provided, stocked, warehoused, and distributed by KEMSA and by public facilities. And it also guides manufacturing sector, importation. It has a wide sector-wide impact. We also have an essential medical supplies list that's being finalized 2020. Actually, I'm told it was finalized last week. So we are just working through the last motions. We have also an essential medical lab list. These tools are necessary to guiding the sector on terms of what to invest in. Quantification of HPTs, only 11 counties have quantified their needs. So on the other flip side, it's not easy for KEMSA to serve the needs of counties when they have not quantified their needs, or facilities when they have not quantified their needs in a scientific manner, so that we can do what is referred to as procurement planning. We should be able to plan for the next 3 years, because you're now engaging in framework contracts for 3 years, for example. So you need to have quantities, estimates that can enable you to engage in that. So that is still ongoing in another 25 or so counties. Basic equipment was already quantified, specifications done, like I said, but funding is the issue we are still working on. Lastly, the issue of enablers. This is very important. So the Ministry of Water, Ministry of Energy, ICT, roads, and the National Treasury, Agriculture for Food Safety and Nutrition. There are many more than the ones here. So there's quite a bit of work going on in fiber optic connection, connecting quite a number of facilities. I believe there were 92. Local area network connectivity for facilities, that is actually ongoing. Then when it comes to water, we have significant challenges in quite a number of facilities that do not have reliable, safe, quality water supply. And this has posed some challenges. So that is also being addressed by the Ministry of Water. So the amount of money actually required for some of this is quite significant. You're referring to, almost 15 billion shillings in a year just to resolve the water issues. Energy actually, Ministry of Energy, KPLC is actually ongoing in a second phase of connections that run till from July to December 2020, connecting facilities to power and connecting them to three-phase power so that those that have equipment that requires that can operationalize that. So this is already sort of ongoing, and this feeds into also Ministry of ICT is developing some, health management information systems, like an electronic health records of sorts. They have multiple modules that they're working in. That's ongoing. They've actually just finished field testing a few weeks ago and are updating them to such. So we want to digitalize health records, move to electronic health records as opposed to paper-based records. So the second question now, as part of my last few slides, the impact of COVID on UHC has been, of course, significant as a global pandemic. The coronavirus, pandemic, which is actually very interesting in the sense that it began in December 21st. It was when it was notified to WHO. It was declared a pandemic in, was it in February? And for Kenya, starting February, March is when we got impacted by it. And so far we have seen the numbers, we significantly impacted. So we've had quite a bit of impact across the various components that I talked about at the beginning. So when it comes to coverage, so for example, COVID-19 stigma, Kenyans have actually kept away from facilities, for fear of contracting COVID-19. So which begs the question, what is the outcome of that in terms of morbidity and mortality for the other diseases that are still ongoing and Kenyans are largely staying at home? What does that mean in terms of us reversing some of the gains we've made with regard to some of these illnesses? So controlled movement to COVID-19 hotspots. Remember, many Kenyans could not access healthcare in Nairobi and Mombasa for quite a bit of time. And so if you could think of that like, a mother who's having complications and is referred to, a higher level facility, a level 5 or a level 6, which is in a controlled movement area. What did that mean? And what is the impact of that? Of course, clearly negative. We've had a few mortalities as a result of that. Exacerbated human resource for health shortages. So when we reassign existing staff who are already, so first and foremost, we had a huge gap. We have a gap of around 200,000 healthcare staff. That's a human resource gap. So some of the counties and facilities are severely constrained. Now we have COVID with no new recruitments, and you are reassigning staff to the quarantine / isolation centers. So there's an impact there. Then we have now almost 600 healthcare staff who are now COVID positive, who have to be in isolation, self-isolation or otherwise. So what does that, and that of course is still progressing. So what does that mean? Now, and then there's this, of course, there's this discussion of more ICU beds, and there's a current work ongoing in counties to reach the target of 300 beds as a minimum. Some have achieved 400. Now, ICU beds come with ratios. You put beds, the more beds you put, the more nurses you need, and the more doctors you need. So that matching, again, you have more ICU beds with the existing human resource. So again, further exacerbating the shortages. And that, of course, has an impact on quality. So disrupted supply chains, this is quite significant. Delayed turnaround times, and this has actually been the case at KEMSA. We've had a shift, to the right in terms of turnaround times, because for some time, KEMSA was in emergency mode. Focus was on COVID supplies, of course, which is expected. It's a pandemic. It's you have to deal with it. Reduced order fill rates. So global supply chains were disrupted. Manufacturing in China was disrupted. Manufacturing, elsewhere was also disrupted. People were staying home, businesses were not operating. And you can imagine what that means if, with international suppliers now delivering their goods. And so we've had stockouts. We've had increased prices, internationally, regionally, and even nationally, right? We've had an increased demand for PPEs. And you have seen a lot of industries shifting to manufacture PPEs. So that's interesting in that sense. Now, the positive effect of that is that there's been local manufacture of PPEs, and now we are shifting towards equipment. And that's a good thing, that it has forced us to start thinking how to be more, self-sustaining. On appropriate medicine news, there's been a serious impact when it comes to fake news on medicines that is causing increased demand and reduced demands for particular medicines. So, once everyone had hydroxychloroquine for COVID, all of a sudden everyone is going to the pharmacies to buy hydroxychloroquine. Then patients who need hydroxychloroquine are not getting hydroxychloroquine. So there's that impact there. When we have an overwhelmed health system. Now, if you remember from the pilot, we said there was an increase in utilization with UHC. Now, COVID has also increased utilization with regard to isolation, quarantine, and ICU beds and ventilators, etc., etc., etc. How do the two interplay in that sense? We've had also, in terms of access, we've had diverted efforts and focus. Of course, everyone in the county, everyone nationally, we all shifted towards, COVID, that effort, and focus in terms of, even in terms of resources, reduced ability to monitor and evaluate. And therefore, and this, we need to innovate and move to more information systems and applications. That's a positive thing. Reallocation of resources, I think that is clear. The negative economic impact, that was made very clear by John. Then when private insurance companies, after receiving premiums, are not reimbursing for COVID-19 related health expenditure. What does that mean? Again, in terms of financial protection, financial catastrophe, equity, equality, etc., etc., etc. In that sense. Then when it comes to planning, we've had, of course, disrupted consultative meetings. I think I referred to that. We, of course, means we've innovated towards online meetings, but to some extent, there's a limitation of online meetings, especially when you're running a workshop for 3 days, for example. Then disrupted HR meetings and processes. I think I referred to this. Delayed the UHC program milestones. So in summary, the interplay between UHC and COVID is still evolving, but in summary is that COVID has made UHC more urgent, more important. There is now even a higher need to ensure access in terms of coverage, to ensure access in terms of quality, to ensure financial protection. Kenyans have lost their jobs, by the way. So what does that mean in that sense? Are Kenyans going to be able to pay NHIF? Kenyans have lost their jobs and they've paid premiums to private insurers. Private insurers are not reimbursing for COVID. So what does that mean again? So there's a very interesting interplay in the three components of access, quality, and financial protection with regard to COVID-19. So lastly, a reminder, of course, to protect yourselves against COVID. Number one, you need to be physically distant, not socially, physically distant. Wash your hands, stay at home. Wash your hands or use a sanitizer, stay at home when you can, if you can. Work from home and invest in a face mask and wear it appropriately when and when needed. So I want to stop there. John, apologies. I think I've actually taken more time than I should have by 10 minutes.
Yeah, thanks a lot, Dr. Nikiba, for your presentation and just breaking down some I mean, giving us at least an update and progress on UHC implementation, especially how the pilot fared, and of course the effect of COVID. So before we get into the Q&A, I would like to request Karen to please switch off turn off your video. Karen, thank you. Karen, please switch off your video. Karen, can you hear me? Thank you. Now, just as a way of summary, the one thing that, of course, Dr. Nyakiba has made clear is that often universal health coverage, the word coverage and care is often used interchangeably, and you've made it clear that the letter C actually stands for coverage and not care, and it's actually about essential health benefit package. And I guess there are discussions around this. Maybe you may need to break it down in terms of what this constitutes, what's the health, what the essential health benefit package constitutes. And again, you've taken us through the scale-up process that it comprises two components. One that is purely input-based, and it's a focus on the primary health care facilities. Component 2 actually basically looks at issues of, it's a combination of inputs and outputs, and this is currently going on post July 2020. And again, yes, you've taken us through the effects of COVID on the implementation of UHC. But I guess what was not very clear is, and of course we acknowledge that this is an evolving issue, and of course you've given us that interplay between UHC and COVID, and the fact that what COVID-19 has presented, or what it portends, is that the more urgent need to roll out this UHC. And I guess we haven't discussed issues of some of the measures that you've taken, or some of the measures that you are taking, of course, in cognizance of the fact that this is an ongoing, it's an evolving issue, but maybe we could discuss those as we go along. So without further ado, I will now open it up for plenary discussions, and I can see there's movement in the chat box. But maybe before I go to the chat box, I would like to invite anyone. You can either raise your hand or unmute your mic. If you have any question or comment to Dr. Nyakiba, you are welcome. Anyone? Okay, I think I'll just read a few, so we'll have like 2 rounds of okay, so I can see Wanja. Douglas,
yes. Thank you, thank you, Dr. Nyakiba, for taking us through this. Actually, it was very enlightening. So my worry is, now the COVID is here, and I think from what he has taken us through, we have seen that even the pilots have had their own challenges. So now, for these counties that were, for example, piloting this UHC, now most of the facilities, I'm sure now, either have been upgraded to become COVID center areas where they can maybe treat the COVID patients. So in the long run, how are we going to, for example, do evaluation and say that this is where we are? So maybe he can shed more light on that.
Okay, thank you, Douglas. Dr. Nyakiba will take another 2 questions, then we turn it over to you.
Okay.
Anyone else? You can either unmute your mic or, yeah, if you raise your hand using that icon there, I'll spot you.
Hi, John. My hand is raised.
Okay, please go ahead.
Yes, so two quick questions. One, the IPAs that the county signed to the national government, when you try to get copies from any of the counties, it seems very difficult to be able to get this. So I don't know if this was deliberate or otherwise. And then secondly, looking at how UHC is structured, the success hinges quite heavily on PHC, including community health. So I wonder, because recently when we had the CHS bill in Senate, the COG said they're not able to pay CHVs, which sort of like puts a stumbling block towards attaining public health care. Most of our issues around WASH. So how is the national government talking to the counties to ensure that there's sort of agreement on this? Thanks.
Thank you. We have another hand. Ian Sagita? Or is it Mugo? Mugo, please go ahead.
Okay. My name is Shelmit Mugo. I had a question on the community health volunteers. To move to the promotive and preventive healthcare, the CHVs are very critical, especially in the rural areas. So will they be paid any stipends? I know in some counties, there are some agreements where they're given some stipends, but in some counties, this has not been done. And this makes some of them to shy off from doing the work. So like most counties should be sensitized on this. Has this happened? That's my question.
Thank you. So I think let's allow Dr. Nyakiba to respond to those questions from the three participants, and then we'll open it up again for another round. Dr. Nyakiba?
Yes. Oh, thank you. Thank you for those questions. Let me start with the first one that John raised, the issue of the essential health benefit package. So what normally happens is that you need to define a set of services that are considered essential, that all Kenyans or all citizens or all residents, depending on how you look at it, should access. So what that means is that there is a defined set of services that you can access, for example, with a minimum NHIF package that you either pay for because you're employed in formal employment, or you pay for as a voluntary member in UHC, in NHIF, or the government pays for you because you are a certified indigent as part of social welfare stroke social protection. And in that way, you all access a certain minimum set of services universally. So that's why it starts with universal. So because of certain realities, you cannot provide everything, and this is particularly for low middle income countries. That's a bit of a challenge starting out. So what happens is that you define what you think to be essential in an essential health benefit package that you are sure Kenyan citizens can access. Now, and Kenyans are already accessing some sort of a, so for example, for HIV, you just go to a clinic, you get tested, and you receive treatment. If it's malaria, you don't get charged. If it's TB, et cetera, et cetera. So all now that we are doing is to put it in some coherent package so that it's very clear to Kenyans, what can I access? Very clear to a provider, what will a Kenyan coming access? And what will, so for example, renal dialysis, I like that example. Right now, if I am not able to pay NHIF, all right, I'm a certified indigent, how do I, and I have kidney failure, how do I access dialysis? I can't. But if it is included in a benefit package and the government pays for me the 6,000 or, et cetera, as shall be determined, then I can access it. Then, for example, the essential package may say that they will only provide 3 dialysis sessions a week. So if I become more ill and I need, 4 sessions, then either I have to get private health insurance to pay for the extra, or I pay out of pocket for the extra 1 session. That clear, so that a Kenyan walking into a facility knows I'm getting 3 sessions paid for by NHIF or this whatever social insurer, and then so that's what we mean by a package. So this package spans across specialized services at level 5 and 6. It spans across basic services in the level 2, 3, 4, and 1, and it also spans across some public health services. So that will also be especially primary healthcare services. Again, you cannot pay everything through insurance there, so you're paying for specific outputs. Of course, government will still have to finance some things, like surveillance and that kind of thing. Those are public funded in approach. Then the second question from Douglas. Okay, maybe I can also highlight. So this package, the panel did a full package. And we are now just in the motions with NHIF of operationalizing, where to start from in a phased manner to achieve that package. That's where we are. So then the question by Douglas, evaluation in terms of COVID in the 4 counties with the facilities being converted to COVID. So the confounding effect of COVID, basically. Yes, you're right. However, for facility, particularly in that question, for facility conversion, that actually happened after February, March, and actually for some counties are converting, in May, June, July. The pilot ended, end of January and slightly in Feb officially. So in terms of evaluation, I think it's not a problem in terms of time. The 2 events followed each other sequentially. UHC pilot ended in, January, end of January, and COVID actually became an issue in Kenya in March. So that might not be. However, if you're evaluating sustainability of the interventions you made, then of course there's a confounding effect between the 2, and that's very true. But in terms of evaluating the impact of the pilot, I think we're good in that sense. Then when it comes to community health, 2 questions with regard to stipends, actually. Now, in the agreements with the 4 pilot counties and in the agreements with the scale up of starting January all the way to July, all our discussions with the counties is that county stipends are, because this is community health services, so county stipends are a county role and responsibility. Counties, of course, have had challenges with that. They have, of course, had some limitations in terms of their wage bill and adding more. They've had to work on county legislation to be able to do that. Some have done that. I think, for example, West Pokot has done that. And then there's also the difference between stipends across the counties. Some paying 2, some paying 2,500, some paying 3,000. So that has also been an issue. So this is still something that is of concern, and I totally agree in terms of ensuring that the community health volunteers can play their role in a facilitated manner. The role of the national government is 1, capacity building. So the counties identify the community health volunteer. The role of the national government, the Ministry of Health, is to train them, and that is actually ongoing, as I said. Number 2 is also as part of capacity building, we have agreed that the national government will actually kit them, especially the new ones, the 31,000 will be kitted in total. The whole 31,000 will be kitted this financial year. So that is so far as at the framework of the IPA, that was the discussions. But of course, we are still having quite a bit of discussion. This is still something that is ongoing in the current IPA. We are still having discussions because as we sign these IPAs, we also try to ensure that each level performs their duties so that we have progress. So I think it is something that is still up for discussion and consultation between the counties. We have multiple meetings with counties, so that is still ongoing in that sense. And it's a valid question. The last question was on IPAs being secret or not accessible, and not being able to obtain them from the counties. No, I don't think that there was nowhere where that was the intention, that IPAs would be secret in terms of accessibility to members of the public. I think that's something that maybe we can take up and see how to address that. Either make some highlights available on the MOH website so that at least you have an idea what it entails. I think that's something we can do from our part. We can also maybe have a discussion with the counties whether they can actually, I don't want to speak for them, so whether they can actually make them available. But there's no discussion or intention to make them secret as far as I am aware of. I think I've addressed I think 4 questions of 5, yes. Is that okay, John?
Yeah, thanks a lot, Dr. Nyakiba. So we'll go to the second round. I think I'll pick sample a few from the chat box and then maybe open it up for maybe 1 or 2. So there are 2 of my colleagues, Stephen Jairo and Darmi. So from Jairo, and I guess you alluded to this, the metrics used to gauge the success of UHC pilot phase. Maybe you could touch on it a bit more. And then his second question, the second question from Steve, is again on the measures that have been put in place, especially for counties in the wake of COVID, for counties which record a high number of positive cases. Is there some sort of prioritization? Then from Darmi Jatani, counties are constantly complaining about national government making collective bargains on their behalf, and they are obliged to honor them despite not being consulted. What strategy has been put in place to ensure UHC is implemented in counties alongside county needs? I think the question on IPA, you've responded to that. Yeah, so those are the ones that I've captured from, I think another one from Douglas is, you mentioned about is it introduction or establishment of a UHC fund? So what Douglas would like to know is the feasibility of this, especially with the onset of COVID and with the many challenges that we've encountered with regard to the pilot. So those are actually the questions that I can see from the chat box. So I hope you've noted those, Dr. Nyakiba. Then I will open it up for only 2 questions before we conclude. Feel free to either raise your hand or you unmute your mic. Do you have any additional questions to Dr. Nyakiba?
Yes, John.
Yeah, please go ahead and introduce yourself.
Okay, my name is Collins Omolo. So first, I would like to thank Dr. Nyakiba for the presentation. I just have 3 quick questions. So on the evaluation report, I've been trying to look for it. I don't know if it's possible that it can be shared, probably in the MOH website, the evaluation report for the pilot in the 4 counties, the lessons learned. If that report maybe could be shared, because I think this is the first time I'm actually seeing it being shared in a public forum. So I don't know if that would be possible. Then on the second question, you've talked about, actually in one of the lessons, you've talked about the issue of frivolous, hospital visits, where there's been an increase in people just want to visit, hospitals because the service is free. So in part of addressing it, you talked about that you'll be identifying indigents So, you classify those who get services for free and those who actually have to pay something to access it. I don't know if you could maybe share the criteria you're using to actually identify who is an indigent and who is not. And then lastly, on the issue of KEMSA, from my experience with the counties, the biggest stumbling block to UHC has been, availability of commodities in hospitals, where the order fill rate, which is, the amount of commodities. Let's say, for example, a county X orders goods from KEMSA worth 100 million. KEMSA is only able to supply, at best, goods worth 60 million. So there's a deficit of commodities worth 40 million. But then, the problem arises where now the counties are not able to get those commodities from another entity, because actually there's a law that makes it mandatory that counties must get all their commodities from KEMSA. I don't know what you're doing to address that challenge of order fill rate with regards to KEMSA. Thank you.
Yeah, thanks a lot. Sorry, I did not capture your name, but yeah, thank you for those questions. Any final question or comment? Dr. Nyakiba, I can see one from Howard Akimala. So what he's saying is that COVID, of course, has greatly affected FP, I guess, is it financial plan? Any word on our FP 2020 targets? I'm not sure what FP stands for. Maybe, Howard, you could clarify that. So I believe...
Yes, it is family planning. Sorry, John.
Oh, family planning. Yeah. So, Nyakiba, you've captured that. Eh? So what COVID, of course, has affected family planning. Any word on what does this mean to the targets, family planning targets, 2020 targets? Maybe you could also weigh in on that. Yeah. Is there any final questions? Is any final question from the participants? So, Dr. Nyakiba, I'll turn it back to you. I only have one additional one. Again, in terms of a stumbling block to UHC, the question on human resource for health, politically, of course, we've had debates about, there are some advocates, we have had people advocating for the need to have a health service commission, something akin to teacher service commission, and that this will help with the questions, the pervasive challenge of HRH, human resource for health. What are your thoughts about this? So thank you. Dr. Nyakiba, I think you can respond to these questions and also make your final remarks. Thank you.
Okay. Thank you very much for the questions. I actually want, in a sense of teamwork also, to share one or two questions with my colleague who is here, so that you can also be aware that I did not come alone. And that is Dr. Koi Mothigani. She will make some comments after I do, so that we also have some, teamwork. But
yeah, that's fine.
Nonetheless, so there was a question. These are very interesting set of questions. Yes, the question on measures for COVID. Is there some sense of prioritization? As you're aware, yes. There is a whole, that's a whole different set of a team working on COVID, and there's quite a bit of work around that, in particular in planning and responding to the COVID pandemic. And this span across multiple areas, from strengthening of disease surveillance, emergency operations, emergency preparedness. We have quite a bit of work in health system strengthening. That is linked to, like what we discussed, setting up ICUs, recruitments ongoing, monitoring evaluation systems, audit and assessments are actually ongoing in the 47 counties as we speak for COVID preparedness. So there's quite a bit of work around that that are key for COVID and that are linked to, so then the prioritization, yes, I think there is some sense of prioritization for the counties with the highest burden, but I do not want to authoritatively speak on that. Maybe I can get back to you after I speak to the COVID team. As you know, this is coordinated by the National Response Emergency Committee. So I need to actually check that and get back to you on that. The evaluation matrix for the pilot, and then there was also a question on the pilot report. Maybe I can tie those two together. So number one is that, so a lot of the issues of the pilot were with regard to, number one, the key was access, right? So a lot of the key KPIs for the pilot were around access of services, availability of the services, so the services being available, availability of the inputs required to produce those services and outputs. There was quite a bit around financing, quite a number of financing indicators, but also in relation to efficiency of operations. It's quite checking the system. So for example, the issue of fund disbursement that I referred to. So you transfer funds to the county revenue fund. So after that, how long does it take for the funds to leave the county revenue fund and go to the facility? And then after the facility has the funds, how long does it take for the facility to actually be able to get authority to incur expenditure and utilize the funds? And then what were the funds used for? Of course, we had some, like I said, reporting issues, but that was pretty much that. And a lot of it was around access and utilization statistics. That was the main, components of that evaluation. There was quite a bit on client engagement, stroke satisfaction, stroke, their participation and their perception of the pilot. And that was also quite important. Now, this all is contained in a pilot evaluation report that has been done together with the counties, which we, of course, once this ended with closure around February, we've actually taken the last few months to do this. The pilot is in, the report is in its final stages. It's actually in top, leadership approval. Yes, and after that, it will be made available to the public. That's okay. So we will do that. It will be shared. Then there was a question around county needs and the UHC fund. So county needs, yes. We've approached UHC as a joint. Sorry for the background noise. There is some fundis somewhere. We've approached UHC as a joint investment, national and county governments. So the way we usually operate is we begin with assessments of need. So and I'll pick two just to highlight so that it's not just theoretical. There are two that I can give you. For example, the issue of human resource recruitments that are ongoing. They were based on one, assessing what is existing, in the human resource databases and reports, but from counties. Two, the gaps compared to the norms. So what are you supposed to have? And then what is your gap? And then from there, now doing an objective allocation criteria that would allocate the resources across the counties. So each of the counties got the human resource that one they needed proportionate to their gap. You have a larger gap, you get more. You have a lower gap, you get less. So, an equitable kind of distribution. It was not equal divide by 47, and it shouldn't be. When it comes to number two, let's pick basic equipment. That was also based on a joint assessment done by the counties themselves, They did an assessment of the equipment status. They shared the reports to the national level. We aggregated, consolidated the reports, and then rationalized the reports to verified and rationalize the reports to now lead to the conditional grant for equipment that is going to go to them. And number two, even despite that, very specific quantities of equipment per county, we are still asking counties to pool the equipment. So you pool what you need, despite you saying I need 100, weighing scales. We will still ask you to actually pool so that we don't, because situation could have changed in the last 6 months or so. So yes, this is county, based on county needs. Every other time, counties have to inform us of the status and need to make it objective. The UHC fund, so the intention of the fund is one, to pool resources for UHC from multiple sources, right? Not just tax revenue, tax funding. So this would include national resources. So Ministry of Health would put money into the fund. Counties would actually put money into the fund, right? It also helps them with ring fencing of funds. And then from there, you're able to use the funds for NHIF, for that is the intention of the fund. We also working through, I wanted to mention that last, but now let me mention it as one of the measures being taken, is that we are working through a health financing strategy. I know this, I'm actually told that this has been the case for quite some time, but we are working through finalizing a health financing strategy that is looking at multiple sources of revenue for the health sector, for purposes of UHC and service provision. So that we are looking at what members will pay for at NHIF. We are looking at tax revenues. We are looking at subsidies for the indigents. We are looking at any other tax sources that should be addressed to healthcare. Maybe part of the sin taxes, for example. Should employers match? So, for example, I am deducted 1,700 shillings for NHIF. Should my employer also pay, because he benefits from my quote-unquote productivity or unproductivity, he suffers from it. So should we also have employers, matching in some of the funding so that we have, et cetera, et cetera, et cetera. So quite a number of options being looked at to make sure that this is sustainable and we achieve some element of equity across the various age groups and cohorts requiring support. Then there was a question of, Collins had asked a question about referrals, which he also mixed with indigents. They're actually different. So the issue of the pilot, the public going to higher level facilities is partly been a health-seeking behavior cultured by the lack of availability of services in level 1, 2, 3. All right. Remember, level 1, 2, 3 is actually free, but the doctor is not there. There's only one nurse in a dispensary, by the way. So when she goes on leave, she closes. There's no facilities, equipment, right? So actually, the feedback we have is that Kenyans were saying that they don't test you, they don't touch you. So then number two, then lastly, there's also the issues of drugs. Kenyans, medicines are a very, very significant component for health-seeking behavior and satisfaction of clients. So when I've gone through the motions and then I don't get what I need, then I'd rather go to the higher level facility, which also partly has more resources to even purchase. So some of the level 4 facilities, for example, purchase drugs from KEMSA directly. The county purchases drugs for them. And now UHC has a conditional grant. So there's been that kind of shift and bias that has facilitated that culture that I need to actually go to KNH to get treated well, or I need to go to Nakuru PGH. I don't want to go to my local health center in Nakuru West. I actually rather take the time to go to PGH and wait for a whole half day to be served. And that's why this intention and shift to primary healthcare and actually matching the investments for the same in terms of making sure that services are available, ready for Kenyans to access them, so that we can shift the bias. It's not, you cannot tell Kenyans to go to a level 3 and then there's no, there's no clinical officer, there's no doctor, there's no nurse, there's no lab work, nothing. And that's why we are now making initial investments in that sense. And other countries have also done the same based on health system capacity. Then there was a question of indigence. It was a very tough question there. So this discussion of indigence is currently ongoing. We've actually just started the discussion. I think we've had like 3 or 4 meetings now with the Ministry, State Department for Social Protection, and together with the counties. So social protection already has social welfare, social protection systems. You remember we already have cash transfers already being done to what, almost 800,000 households. So we are exploring all these criteria used by the state protection, State Department for Social Protection. We are looking at counties. I am aware of, in fact, we were just listening to Muranga the other day. They've already mapped, for example, their indigents, and they've declared them to be around 27,000. Like Kipia has also done the same. And they have actually already started paying for a portion of those indigents at county level. So we are still, and I agree with you, the criteria is very important. What criteria do you use to identify who is an indigent? The process is very important. So who approves? Do I go to the chief? Or do I go to the ward administrator? Or do I do it online, like the Kazi Mtaani, where you go to the chief and he uploads all your details in the system? Is there now someone nationally who is approving it? So we are still working on harmonizing these systems to achieve one efficient system that can also be respectful of COVID, minimizing physical interaction, So that is still actually ongoing, and we are cognizant that we need to be very clear on the criteria, very clear on the process nationally, so that all Kenyans who are potentially indigent can have equal opportunity to be listed. Then there was a last question on order fill rates. They are low versus the KEMSA law. Yes. Okay, so order fill rates at KEMSA have been, of course, counties have complained, and it's due to several factors. It's some of the factors are internal to KEMSA. That's a reality. By the way, that's a reality. We do have certain issues to resolve at KEMSA. Some of the factors are external to KEMSA. So let me mention a few. So let's start with some of the challenges in processing the orders at KEMSA have been leading to long turnaround times. Some of the challenges with suppliers have been leading to stockouts. Some of the processes for warehousing and distribution have been leading to, KEMSA has done reasonably very well actually in distribution. KEMSA delivers to the facility, by the way, 100 last mile delivery. And you can imagine the number of facilities in every county. So distribution is good. So what we just need to do is improve efficiencies within KEMSA in terms of how it turn around times. And that's actually happening in that sense. Number 2 is external to KEMSA. We have factors, for example, counties owe KEMSA, at any one time around 2.5, 2.7 billion shillings. KEMSA operates like a revolving fund. So I supply you, you pay me, I do a small margin, usually around 10, something percent to cover my overhead costs. And then I pay my suppliers. So when national government and when counties owe KEMSA billions of shillings, it significantly impacts operations. Another one, counties have not, like I said, only 11 counties have quantified their needs. So KEMSA is not able to forecast forward for 3 years and operate with suppliers at a more efficient level. And lastly, when a county, let me not say the county, let me just say, when a county disappears for 9 months, because it has a debt that it has over 150 million, 100 million that it has not paid, to KEMSA, so its account is suspended. And then all of a sudden you make the payment and you make an order of 150 million of items that are not even on a standardized list. Then we have challenges there with achieving that. So lastly, just to say that, yes, so there are significant issues around that. So what are we doing? Number one, like I said, we are standardizing the lists for medicines, medical supplies, lab, and even equipment. Two, then that ensures KEMSA is working on a predictable list. Two is we are working on how to improve this debt management or credit management with the counties, with the referral hospital. That needs to be improved. Then there is the whole issue of a set of KEMSA reforms. So the ministry is actually engaged with the KEMSA on some set of reforms to improve its procurement, warehousing, distribution, storage functions, improve a bit of efficiency around that. So for example, KEMSA is working with meds. When you don't have something, you're able to get it quickly so that you serve the counties and then you sort your issues later, etc., etc., etc. So there's quite a bit there. Lastly, the KEMSA law. So counties a law was passed by Parliament, and then counties went to court to challenge the law. The court case is still ongoing. However, there is actually there's a lot of discussion with the counties on how to resolve this out of court, and and there's general agreement that KEMSA needs to be the first point of call. So I make my 100 million order with KEMSA, but KEMSA needs to maybe within a few hours respond that they only have 70 million worth of items. And therefore the law should allow me now to go to my second point of call, which can be meds, so that my 30 million is served from another verified supplier. Reason being, it should not interrupt service delivery. So we have discussions around that, and we are actually willing and ready and looking forward to an out-of-court settlement with the counties and to engaging Parliament to, do that. That's the last update that I have. There was a question, John, you asked something about human resource. Maybe I didn't. Please quickly recap what you asked about human resource for health.
Yeah, it was just about, we have some advocates or proponents for...
commission.
Yeah, the commission, whether, that's clawing back devolution or how useful this would be in terms of HRH,
That's yes. I'm not able to give you a Ministry of Health position on that. That's a political issue. But I'm aware there are discussions around BBI. Of course, we are here to see the report around the commission. Health workers have been advocating for the commission. Counties have been not very excited about it. Let me put it that way. So I think there are still ongoing discussions around either the commission in full or an advisory agency of some sort that can perform some of the functions across, to facilitate some of the issues we are having, disparities across counties. I think that discussion has not concluded, so it's difficult because every time I attend a meeting, there's a new discussion. But let me just say the discussions are ongoing, and I think it's with the political leadership and the top leadership of the ministry to we are waiting for conclusion of that discussion. As you know, the BBI discussion is also, we are all waiting for the report and from where discussions will flow in terms of how we approach this. I think the only people who are very clear on this are health workers. They have come out very clearly, categorically, in support of the commission. I think the ministry is still weighing. The counties have been clear in terms of not very excited about the commission. I think the ministry is still, discussing, and once a position is set, that will probably be shared. That's as a political answer I can give as possible. Lastly, maybe Dr. Koi, please answer the question, respond or make a comment on the FP targets for 2020. There was a question around that. As you make a quick comments around that.
Hi, thank you, Dr. Nyakiba, and we are very grateful to be part of this forum and to inform the public and to have interactions with the public on UHC, and especially now where health has become a key highlight in our everyday life thanks to the COVID-19 pandemic. So in response to the question about family planning and our targets and whether we're going to reach people as much as we have been in previous years, I'd like to say that COVID-19 has had, and I think will continue to have, a profound impact on the lives of people across this country and I think across the globe. So as the health system shifts to prevent and treat people with COVID-19, there are many basic health services that have been disrupted. An example is immunization, antenatal care services, postnatal care services, and in the same breath, family planning services. So in terms of, or an example I can give is sexual and gender-based violence issues that have been brought up a lot in the news. You find there's an increase in domestic violence, intimate partner violence. There's also an increase in teenage pregnancies. And with that, all sexual and reproductive health services have really been impacted on the downward trend due to COVID. There's also more factors that are non-health factors that are contributing to this shift. And that includes the economic upheavals, where you have reduced income for women, therefore they become vulnerable in this economic crisis, and it hampers their access to voluntary family planning services, such that before you could walk to maybe a pharmacy and access the services, but now you may not have the economic power to do so. Then we have had a pretty much stay-at-home order, and in situations where women are not open with their partners, then they cannot discreetly access family planning services because you're always in the same vicinity as your partner. So those are just snapshots of what is really happening in the health system, but it shows that there's been a great impact on family planning information and services. And this disruption, unfortunately, comes at a time when we need even greater family planning services, especially for teenagers, young women, and women who have been affected by the economic crisis. So we will see a big shift in terms of the reduction of access to sexual and reproductive health services, including family planning. And this then gives us the impetus to gear up all our services that have been impacted negatively by our focus on COVID-19. I think I'll hand back to the chair if there are no further questions.
Yeah, thanks a lot to Dr. Nyakiba and indeed Dr. Wangui. We are very grateful to the ministry and to the two of you as speakers who educated us on the UHC. Of course, you've shed light and provided insights actually on where we are, the effects of COVID on this, and touched on some of the things that we are thinking for the future. So we are very grateful, and I would like to ask my fellow participants basically to give you a clap wherever they are. I mean, to clap for you wherever they are, and to just give you a thumbs up. So thanks a lot for sparing time to help in discussing this important public policy issue. Just to mention, this is actually part of a project that we are undertaking on governance for health that's funded by Open Society Initiative for East Africa, and we'll be following up on this, the developments around UHC, among other health sector issues. We've been able to actually identify things that will be useful for further research and further engagement, and the things that we've captured from this will produce a bulletin that we'll later share. And of course, we're actually looking forward to the evaluation report on the pilot, UHC pilot. So please, Dr. Nyakiba, keep us posted. As soon as that's posted, that's been posted by the ministry, please let us know. Otherwise, thanks a lot to everyone. And just to mention that, of course, IEA is the Institute of Economic Affairs is a think tank, and we are a membership organization, and you're welcome to be a member of the IEA. Please visit our website or call our communication team if you're interested. And of course, they will take you through the process of registering to be a member. And just also to mention that this discussion will continue in our social media pages, and we'll post the presentation on our website, and also look out for other webinars that will be coming up in the next few days. Otherwise, thanks a lot and have a good afternoon. Thank you. Bye-bye. Thanks a lot, Nyakiba, again. Yeah, thanks. Bye.
Asante John, and asante everyone.
Yeah, thank you.